Hi guys, today we're going to be continuing cell death from Pathoma chapter 1. If you haven't watched the first video, please go and watch it. It discusses growth adaptations and cellular injury. Cell death. Basic principles. The morphological hallmark of cell death is loss of the nucleus, which occurs via nuclear condensation, pycnosis, fragmentation, karyohexis, and dissolution, karyolysis. The two mechanisms of cell death are necrosis and apoptosis. Necrosis. Death of large groups of cell followed by acute inflammation due to some underlying pathologic process, never physiologic, divided into several types based on gross features. Gross patterns of necrosis. Coagulative necrosis. Necrotic tissue that remains firm. Cell shape and organ structure are preserved by coagulation of proteins, but the nucleus disappears. Characteristic of ischemic infarction of any organ except the brain. Area of infarcted tissue is often wedge-shaped, pointing to focus of vascular occlusion and pale. Red infarction arises if blood re-enters a loosely organized tissue, pulmonary or testicular infarction. Here we have the picture of coagulative necrosis. This is the gross appearance of coagulative necrosis of kidney. This is the microscopic appearance, and they're giving you a normal kidney histology to compare. Here we have hemorrhagic infarction of testicle. Liquefactive necrosis. Necrotic tissue that becomes liquefied. Enzymatic lysis of cells and proteins results in liquefaction. Characteristics of brain infarction, where proteolytic enzymes from microglial cells liquefy the brain. Abscess, where proteolytic enzymes from neutrophils liquefy tissue. And pancreatitis, where proteolytic enzymes from pancreas liquefy parenchyma. Gangrenous necrosis. Coagulative necrosis that resembles mummified tissue, dry gangrene. Here we have a picture of dry gangrene with the mummified tissue that they were talking about. Characteristic of ischemia of lower limb and GI tract. If superimposed infection of dead tissue occurs, then liquefactive necrosis ensues and wet gangrene occurs. Caseous necrosis. Soft and friable necrotic tissue with cottage cheese-like appearance. They're showing us caseous necrosis of the lung right here, and you can see the cottage cheese appearance right here. Combination of coagulative and liquefactive necrosis, characteristic of granulomatous inflammation due to tuberculous or fungal infection. Fat necrosis. Necrotic adipose tissue with chalky white appearance due to deposition of calcium. So here we have a figure of fat necrosis of peripancreatic adipose tissue, and it's giving a chalky white appearance due to deposition of the calcium. Characteristic of trauma to fat, for example, breast, and pancreatic mediated damage of peripancreatic fat. Fatty acids released by trauma, for example, to breast or lipase, for example, pancreatitis, join with calcium via a process called saponification. Saponification is an example of dystrophic calcification in which calcium deposits on dead tissue. In dystrophic calcification, the necrotic tissue acts as a nidus for calcification in the setting of normal serum calcium and phosphate. Metastatic calcification, as opposed to dystrophic calcification, occurs when high serum calcium or phosphate levels lead to calcium deposition in normal tissues. For example, hyperparathyroidism leading to nephrocalcinosis. Fibrinoid necrosis. Necrotic damage to blood vessel wall. Leaking of proteins, including fibrin, into the vessel wall results in bright pink staining of the wall microscopy. Here we have a figure of this, fibrinoid necrosis of the vessel, and it will be bright pink. The vessel walls will result in bright pink staining of the wall. Characteristic of malignant hypertension and vasculitis. Apoptosis. Energy ATP-dependent, genetically programmed cell death involving single cells or small group of cells. Examples include endometrial shedding during menstrual cycle, removal of cells during embryogenesis, CD8 positive T cell mediated killing of virally infected cells. Morphology. Dying cell shrinks, leading to cytoplasm to become more eosinophilic. Here we have a picture of apoptosis. Nucleus condenses and fragments in an organized manner. Apoptotic bodies fall from the cell and are removed by macrophages. Apoptosis is not followed by inflammation. Apoptosis is mediated by caspases that activate proteases and endonucleases. Proteases break down the cytoskeleton. Endonucleases break down the DNA. Caspases are activated by multiple pathways. Intrinsic mitochondrial pathway, cellular injury, DNA damage, or decreased hormonal stimulation leads to inactivation of BCL2, which is B-cell lymphoma 2. Lack of BCL2 allows cytochrome C to leak from the inner mitochondrial matrix into the cytoplasm and activate caspases. Extrinsic receptor ligand pathway. FAS ligand binds FAS death receptor CD95 on the target cell, activating caspases. For example, negative selection of thymocytes in thymus. Tumor necrosis factor binds TNF receptor on the target cell, activating caspases. Cytotoxic CD8 positive T cell mediated pathway. Perforins secreted by CD8 positive T cells create pores in the membrane of target cell. Granzymes from CD8 positive T cells enters pores and activates caspases. CD8 positive T cell killing of virally infected cell is an example. Free radical injury. Basic principles. Free radicals are chemical species with an unpaired electron in their outer orbit. Physiologic generation of free radicals occurs during oxidative phosphorylation. Cytochrome C oxidase, complex 4, transfers electrons to oxygen. Partial reduction of oxygen yields superoxide, hydrogen peroxide, and hydroxyl radicals, or OH. Pathologic generation of free radicals arises with ionizing radiation, where water hydrolyzed to hydroxyl free radicals. Inflammation, NADPH oxidase generates superoxide ions during oxygen-dependent killing by neutrophils. Metals, such as copper and iron generates hydroxyl free radicals, Fenton reaction. And drugs and chemicals. P450 system of liver metabolizes drugs, for example acetaminophen, generating free radicals. Free radicals cause cellular injury via peroxidation of lipids and oxidation of DNA and protein. DNA damage is implicated in aging and oncogenesis. Elimination of free radicals occurs via multiple mechanisms. Antioxidants, for example glutathione, vitamins A, C, and E, enzymes, superoxide dismutase in mitochondria, superoxide converts into hydrogen peroxide, glutathione peroxidase in mitochondria, where 2-GSH plus free radicals is converted to glutathione disulfide and water. Catalase in peroxisomes, where hydrogen peroxide is converted to oxygen and water. Superoxide and water. Metal carrier proteins, for example, transferrin and ceruloplasmin. Examples of free radical injury. Carbon tetrachloride, organic solvent used in the dry cleaning industry. Converted to CCl3 free radical by P450 system of hepatocytes. results in cell injury with swelling of rough endoplasmic reticulum, consequently ribosomes detach, impairing protein synthesis. Decreased apolipoproteins lead to fatty change in the liver. Reperfusion injury, return of blood to ischemic tissue results in production of oxygen-derived free radicals which further damage tissue. Leads to a continued rise in cardiac enzymes, for example, troponin, after reperfusion of infarcted myocardial tissue. That's all for today. Here we have our figures from the previous page of fatty change of the liver. Amyloidosis. Basic principles. Amyloid is a misfolded protein that deposits in the extracellular space, thereby damaging tissues. Multiple proteins can deposit as amyloid. Shared features include beta-pleated sheet configuration, Congo red staining, and apple green birefringence that when viewed microscopically under polarized light. Systemic amyloidosis. Amyloid deposition in multiple organs divided into primary and secondary amyloidosis. Primary amyloidosis is systemic deposition of amyloid light chain amyloid, which is derived from immunoglobulin light chains. Associated with plasma cell dyscrasias, for example, multiple myeloma. Secondary amyloidosis is a systemic deposition of AA amyloid or amyloid A amyloidosis, which is also known as a secondary AA amyloidosis, which is derived from serum amyloid associated protein SAA. SAA is an acute phase reactant that is increased in chronic inflammatory states, malignancy, and familial Mediterranean fever, FMF. FMF is due to dysfunction of neutrophils, autosomal recessive, and occurs in persons of Mediterranean origin. Presents with episodes of fever and acute serosal inflammation, can mimic appendicitis, arthritis, or myocardial infarction. High SAA, or serum amyloid associated protein, during attacks deposits as AA amyloid in tissues. Clinical findings of systemic amyloidosis are diverse since almost any tissue can be involved. Classic findings include nephrotic syndrome, kidney is the most common organ involved, restrictive cardiomyopathy or arrhythmia, tongue enlargement, malabsorption, and hepatosplenomegaly. Diagnosis requires tissue biopsy, abdominal fat pad and rectum are easily accessible biopsy targets. Damaged organs must be transplanted. Amyloid cannot be removed. Localized amyloidosis. Amyloid deposition usually localized to a single organ. Senile cardiac amyloidosis, where non-mutated serum transthyretin deposits in the heart, usually asymptomatic and present in 25% of individuals more than 80 years of age. Familial amyloid cardiomyopathy. Here we have a picture of amyloid with the Congo red and apple birefringence. Mutated serum transthyretin deposits in the heart leading to restrictive cardiomyopathy. 5% of African Americans carry the mutated genes. Non-insulin dependent diabetes mellitus type 2. Amylin derived from insulin deposits in the islets of pancreas. Alzheimer's disease. AB amyloid derived from beta amyloid precursor protein deposits in the brain forming amyloid plaques. Gene for beta APP is present on chromosome 21. Most individuals with Down syndrome, trisomy 21, develop Alzheimer's disease by the age of 40, early onset. Dialysis-associated amyloidosis. Beta-2 microglobin deposits in the joints. Medullary carcinoma of the thyroid. Calcitonin, produced by tumor cells, deposits within the tumor. Tumor cells in an amyloid background. Thank you, and we're done with reading the first chapter of Pathoma. Please join me in my next videos as we continue to read through the chapters of Pathoma together.